Dr. Kotlow had published it, I published it, I presented it to the American Academy of Pediatrics at one of the national meetings, that potential ties or ties should be put on the differential. Doesn't mean that all ties cause reflux, but just think about it. We see so many of these children swallowing so much air when they're feeding. And we see it in older kids, we see it in adults as well. But what we look at is we look at lip seal, we look at disorganization of their sucking and swallowing. So many of these babies and children are coming in with disorganized sucking and swallowing. They're chomping, they're gulping, they don't have good lip seal, they're sucking and swallowing a lot of air. Parents say, I can hear them swallowing the air. Their stomachs are distended. They can hear their stomachs afterwards. And we found that it was published in Pediatrics. I also published it in another journal. In one of the studies we were looking at retrospectively, it was about 50%. One of my colleagues saw about 80% of the babies that he was treating, their reflux settled in the, what we call contemporaneously, within the time frame of the healing process of the surgery, within the first 1 to 2 weeks, where we were able to get a lot of these babies tapered off their reflux medications, and they kept that way, at least through the first 6 months. So that's one thing that we're looking at. Now, we talked about kinematics, and what that is a fancy way of talking, or technical term, is tongue motion. We call it peristalsis, that wave-like motion of the tongue. That tongue being able to rest or get up to the roof of the mouth, not only for feeding, but how is this potentially going to spin off into what we're talking about today as far as airways and growth and development. So this is kind of a study we were able to publish this past year, which we did with Columbia University, the Department of Biomedical Engineering. What we did was we did ultrasounds of tongues and feeding and sucking and swallowing before and after lingual phorenectomy. And what we found is tongue organization improved immediately. So what we want to look at, and I don't have time to do this at this point, but normal tongue motility here really should kind of be in this nice organized wave-like motion. The middle and the back part of the posterior part of the tongue should elevate and hit the hard, soft palate junction and drop down. When they can do that on the breast, they can draw your nipple deep into the mouth. They can actually transfer milk in a nice, even flow way. In a child that's got a potential tongue tie, that tends to be a little bit more disorganized. It might not show up as well here, but that tongue motion is kind of all over the place. When they feed that way, often what happens is the nipple stays more towards the front of the mouth. The moms develop a shallow latch. The baby starts to chomp. It becomes painful in their feeding. They're gulping. They're swallowing lots of air. They're exhausted. Their suck, swallow, breathe patterns become what we call disorganized. And, they don't sleep well at night. There's a lot of things that we see. We see a lot of these kids, the parents report, my baby doesn't sleep. And so we were able to publish that, and we showed improvements in lingual range of motion and motility and organization. And then what we have is trying to measure infant sleep quality, looking at objective parameters, looking at actigraphy, which is movement, looking at the Brief Infant Sleep Questionnaire, which is a validated questionnaire for infant sleep, and looking at other objective parameters, which we were looking at salivary cortisol and melatonin levels before and after lingual phorenectomy. We see so many of these kids and adults coming in with sleep-disordered breathing. Many of them had ties. There's been research looking at that. It's being shown. It was shown by Guilleminault. So at what point does this start and develop? Probably in utero. We don't have the ability to change the genetics at this point or treat them in utero, so we're trying to screen them out as newborns. And this is the next step that we're looking at to try to get some more objective criteria out there, looking at infant sleep and our ties causing sleep disorder breathing in infants and the newborns. One of the short answers is yes. This process and this project is actually ongoing right now, but we have some early data to show that we start seeing some improvements in infant sleep pretty soon after we do these lingual phorenectomies. This was presented at one of the Airway conferences as well last year. What we're looking at is actigraphy. I'm not going to get into the details here, but we have a little watch that actually goes on the baby's ankle, and that's measuring their movements at night. We get the reports that so many of these babies are so restless at night. Are they having reflux? Are they swallowing air? Are they just obstructing? Are they developing sleep-disordered breathing? Is sudden infant death syndrome a potential piece of the puzzle there? There's a lot of big questions that we're trying to come up with, and the more you try to answer, the more questions come up and the more research projects it starts to develop, and we just don't have the time, we don't have the funding, we don't have the people interested in doing it, so it's a very difficult thing for us to do. Although it's changing, and like we say, it's changing one tie at a time, it's changing one airway at a time, it's changing one person at a time, it's changing one pediatrician at a time who starts to say, maybe I don't know, I'm not sure, we'll send it out to people who may know a little bit differently. I'll kind of wrap it up here, but one of the things that we were seeing is that we were seeing improvements in wakefulness and lessened infant movements during the night. We're still in our process of collecting salivary cortisol and melatonin samples at this point to look at. But we're giving a shout out to Staten Island here, because if you look on the slide here, the lead author of our study here, Ruth Marciliani, who's an oral myofunctional therapist at NYU, is working on her master's at College of Staten Island. So a big shout out here, because she's working in neural development, and this is her baby, her project here, because we see these issues all the time. And we presented this as kind of a pilot study to get up and running. We have funding from the NIH for it, and there's going to be more to be dispelled about it. But we got to start somewhere. So these are all places for us to start and to try to see where it grows. What I knew yesterday changes today. Knowledge, as the quote says, knowledge has to be improved, challenged, and increased constantly, or it vanishes. And we're not trying to create something new here. We're just trying to understand what's going on. And I think that's really kind of what I'm trying to drive home here. But yeah, this is my crew here. I have 3 kids, and that's my girlfriend in the middle. My wife doesn't like to be in the pictures, so. But my oldest on the left, that's Teddy. She's my opera singer. She's had 2 tongue tie releases. She worked with Joy Moeller out in California for oral myofunctional therapy. She's an opera singer, so she saw an opera ENT, and she had a septoplasty, turbinectomy, and adenoids taken out twice, once as a child and whatnot. She had palate expansion, and I missed her tongue tie from the get-go, so I was more attentive to my others. My middle one there in the middle, that's William. He's 16. He'll be 17 in March. And then my redhead is my Instagram influencer. As I think Lisa knows. She's taught me how to use Instagram. But and that's Juliet. She's a freshman at University of Texas. But and that's Lila, my baby, in the middle there. But thank you.